test. So kindergarten cop fans. I think I tried to hyperlink it to the clip. I don't know if you guys can click on it. Does it work for you guys? I'm trying to get fancy. Did I update the slides? This is in GU. No, I didn't update the slides. You don't have a picture? The chemotherapeutics? Oh, there's 2 chemo lectures. Yeah. So the other, so yeah, that's a good point. Thank you for housekeeping purposes. And yeah, so there's 2 chemo presentations. One I gave you guys just for completeness sake. That one I'm not going to be pulling test questions from. I'm only pulling test questions from this chemo presentation. The other one there is just there for completeness sake, and if you want it, and maybe on rotations, or maybe if you end up working with an oncologist or something, it may be relevant, but I'm not going to be pulling test questions from that other one. So yeah, thanks, Tori, for that one. So this one is the one that's testable, so on exam. So it's in GU. I don't know if... Oh, OK. So kind of the same thing. This is not going to be for specialists, so don't share this with your oncology friends or whatever. They're just going to laugh condescendingly. Ha ha ha. You call that chemo? But this is just basic understanding for general healthcare practitioners, for pharmacists, physicians, PAs, et cetera. And then I try to focus on high yield stuff, so the chemo topics that you'll see on board, or that will be relevant to board. Also, too, most of you guys probably won't work with an oncologist. I mean, if you do, you'll get really good at it. It's like with pharmacy. Most pharmacists don't know a lot about chemo drugs unless you work for, like, there's Texas Cancer Centers, I think, is down here. I know there's some pharmacists that work down there, and they know, everything about chemo. So this is going to be a general overview, basic understanding. So Super Hang On. This is an old Sega video game. I don't know if you guys remember this motorcycle game. It was fun. '89 was a good year for me. No. But I put these in here as transitions to kind of chop up the presentation. So that's what those are for. So just basic definition. And have you guys already gotten cancer and pathophys? No, not yet. OK. But just basically, cancer is an overgrowth of cells. So it's an overproliferation, excuse me. And it becomes pathological. So the goals of cancer chemotherapy are to selectively, if you can, destroy the cancer cells and not the normal cells. And then which is a really hard thing to do. And then you want to try to minimize toxicity to the patient, and then more specifically the normal cells. So you want to try to get as much of a targeted therapy as you can. And this is unlike antibiotics, because with bacteria, you have a drug to kill the prokaryotic cell, but it's easy to not kill your eukaryotic. So with antibiotics, it's a more, it's anti-life, right? So antibiotics sometimes are under the chemotherapy label, but it's specifically for the bacteria, and they have different cell types in us. Versus with cancer cells, the cancer cells look a lot like our normal healthy cells, so it's really hard to differentiate what you're trying to kill. So it's very important to target those. And then you'll see where they affect different stages of the cell cycle. And some of the classifications of chemotherapy drugs will mention, S phase specific, or et cetera. So and this is what it is, the cancer drug cell cycle. This is where I was talking about S phase. So I want you guys to look at these, and I do want you to memorize which medications fall under which part of the cell cycle. So which ones hit M phase, which ones hit G, et cetera. So so you at least be familiar with where they fit. And then here's a list of some that are going to be cell cycle specific, CSS, and some are cell cycle non-specific drugs. So again, look at these lists and make sure you're familiar with these medications that fall into this categorization. Because like with a lot of things in pharmacy, a lot of times it comes down, especially if you're not a specialist, it comes down to categorization. So a big reason that there's toxicities and side effects and kind of those classic side effects is that a lot of healthy cells, bless you, rapidly divide under normal conditions. So your bone marrow, your hair, and the lining of your GI tract. So with adverse effects with chemotherapy, those are the three areas that you'll see a lot of adverse effects. So that's where you stereotypically think of the cancer patient not having hair or having the hair loss, is because these medications, yes, they're targeted for the cancer, but then they also will kill the cells that are responsible for hair growth. So this is where you get most of the side effects, and then this is where you have that classic, so to speak, chemotherapy. So anemia because of the bone marrow, hair loss, and then sores, ulcers in the mouth and the esophagus, and then nausea, vomiting too, which is a GI adverse effect. So be familiar with these. I definitely want you guys to know, for testing purposes and for boards, etc. Definitely know of adverse effects for these chemotherapy drugs. So, and this is also important and kind of related to it. They have common and signature. So the specific drug will have a signature adverse effect, meaning that you can kind of pair them together. This chemotherapy has this signature. But the ones I want you guys to be familiar with and definitely commit to memory and look at are the common shared adverse effects. I talked about some of those a little bit on the previous slide here. These are common. But then here's a more complete list of those. And again, that's part of that common picture that you'll see with the patient who has chemotherapy. Because I mentioned earlier, I was making a prediction about your future practices. You probably won't maybe work with an oncologist, but you probably will see a patient that either is undergoing chemotherapy or has undergone chemotherapy or will undergo chemotherapy. So that's where some of these kind of broad topics I want you guys to be exposed to, just because you might see some of these things on their charts and you need to be able to make the connections. There's also acute versus chronic effects, so pay attention to those and look at those. So acute just means that these are the ones they're going to get earlier on, versus chronic, they'll have it longer term, and the longer they're on medications, the chemotherapy, the more likely they'll have that. So the big one here, and that you hear about a lot, and there's specific guidelines for, and I could give a whole 3-hour lecture on, is chemotherapy-induced nausea, vomiting, so CINV. It's the most prominent acute effect. Can cause dehydration, malnutrition, metabolic disorders. And we've already been over this, but you typically go with antiemetics. So I mentioned the serotonin antagonist. So ondansetron, which is generic for Zofran, that one's really popular. And then sometimes some of the older antipsychotics, so the phenothiazines maybe. And then et cetera, I put here, just stay tuned. I have a whole section on chemotherapy-induced nausea, vomiting. And we'll go into more detail as far as what makes sense for which patients, et cetera. But the Zofran is definitely a big player, and you seen that used a lot. Delayed effects or more common, chronic effects. The myelosuppression is something you have to be concerned with. So this is where bone marrow activity is decreased, and with these results, so you have less red blood cells, less white blood cells, and less platelets. So you may have leukopenia, thrombocytopenia, and then an increased risk of infection or bleeding. So you do have to be thinking about that longer term when a person's on chemotherapy. Some more delayed effects. So the GI effects are usually more delayed. Alopecia too, neuropathies, hand-foot syndrome. So you'll notice I have some chemotherapy drugs in parentheses there. Those are signature. With those, remember I mentioned there's common adverse effects and there's signature adverse effects. So for vincristine, a signature adverse effect is the neuropathy. So that's what those are there, just as an example. DRM. So like with antibiotics, you do need to be concerned about drug resistance mechanisms. So the cancer cells are evolving, or that they react to the noxious stimulant we're giving them, the chemotherapy, and they adapt and they evolve kind of quickly. And so you sometimes, unfortunately, have drug resistance mechanisms. And you can't achieve a total kill. So that's where you hear, well, it'll be in remission, or it will get part of it, or it's not completely gone, or you'll hear lay public, or probably friends, family members, et cetera, future patients, et cetera. But it's unfortunately that there is some drug resistance. So because of that, combination chemotherapy is the rule, not the exception. So you usually want to go with a multi-pronged approach, and because of that resistance, you want to be attacking the cancer, so to speak, with a lot of different chemotherapeutics. So definitely remember that. That's something to think about. So it'll be rare to see someone just on one chemotherapeutic. I'm not going to say never. It's not as common. So and then with the resistance, there's primary and secondary, and then multi-drug resistance. But it's just referring to the time. So primary is what where the tumor cells initially are not sensitive to the given drug. Secondary resistance is that the tumor cells develop resistance. So you can think of primary resistance as like an inherited resistance they have, versus a secondary resistance is after they're exposed to the chemotherapy, then they develop the resistance. And then interesting kind of fun fact. So you guys remember verapamil's a calcium channel blocker. It can actually help with multi-drug resistance. So, and the theory goes is that the multi-drug resistant cells have reduced accumulation of drug because increased number of the P-glycoprotein drug efflux pumps, and verapamil blocks these, so it helps with the multi-drug resistance. It is one of those mechanisms of action. Last year, a student and I had like an hour-plus long conversation about it. It is still being debated, and there is some other information out there that may be kind of, it's just basically, it's a mechanism of action that's not fully elucidated, as they say. So I had a student last year that, and I enjoyed it. It was good. It was fun. But he was always pulling primary resources, primary studies, and like, what about this, Dr. Shaw? So we had an interesting exchange about this. But so take-home point is that this is the most current theory, and that these verapamil specifically helps block that. Dose-limiting toxicities. So this is something where the idea is like we have a great chemotherapy drug, and it's going to kill this cancer cells, and it's going to treat it, and we're going to get rid of it 100%. However, it's also going to kill the person 100%, right? So it's just like, it's a really great drug and it's going to kill the cancer, but like because of the reason I mentioned earlier, it's hard to kill the cancer without killing the patient. So that therefore you have dose-limiting toxicities. So this is Chemo Man, or Chemo Tx Man. He's a superhero. To help you guys and remember the common chemo toxicities. So look at this, pay attention to this. But the C's here are for his ears, so acoustic nerve damage and nephrotoxicity. So they also put a C here for the kidneys. Have you guys seen this before? Maybe, maybe not. Okay. Vincristine, peripheral neuropathy. So that's where you have the V's here for vincristine. Bleomycin, pulmonary fibrosis. So you have it here for the lungs. Doxorubicin, you have a D for the heart, cardiotoxicity. Same thing with the T there. And then the C's I mentioned already. And the CY, hemorrhagic cystitis, you have it here for the bladder. And then the 5-FU and 6-MP, myelosuppression, so here for the bones. And then methotrexate, which we'll see in the rheumatoid arthritis. But you also have that. You also have to be concerned about myelosuppression there. So I think this will help you guys study and be familiar with these. And it's not that I'm just giving you guys stuff to memorize. This is just they ask about these on board questions. So again, I'm going back to that theme. I'm trying to get you guys exposed to things that are high yield, that are more likely. So Chemo Tx Man was developed because of board questions. So you'll see these specific chemotoxicities. And so this helped me memorize them. But so memorize this, please. Look at these. Dose-limiting toxicities. Here's some more that are listed. Cardiotoxicity, hemorrhagic cystitis, and renal autotoxicity. And those are repetitive somewhat, I think. But these are these also are kind of board-heavy, high-yield toxicities that they like to ask questions about. I kind of wonder, I have a dream. When I was a boy, I had a dream. No. Now that I'm in academia, I kind of want to go to see who these board question writers are and like go to their, I'm pitching them, they're like in some dark basement or something, some evil headquarters that they have. But I want to go there and kind of, because like some of the stuff's like, why do you guys stress so much about these doses? I don't know. It's interesting. I'm assuming they have a good reason. It's not just to torture students. But so maybe one day I'll get on the other side, get a peek behind the curtain, so to speak, and see why some of these things they consider important. Because as a practicing pharmacist, it was on our board questions, but a lot of this stuff I memorized for my class and for my boards, and I've never seen any of it, other than the time that I sprayed myself in the face with chemotherapy in the hood. But other than that, and I literally saw it right in front of my face. But as far, so it's, I don't know, interesting stuff. Question or stretching? Stretching. Or just giving up on life? No, it's just, okay. Just, like dose-limiting toxicities. I hate these. This is another one that they like, but so look at these. So these are specific agents to help prevent toxicities. Again, see these on the boards, et cetera. So these are the cytoprotective agents, and then this is a toxicology. You may see this again in the toxicology lecture, but I put it here because these are specific for, and so these are the antidotes, so to speak. Mesna. I always try to say Mensa. Mesna. And so it says required/frequently. So Mesna is required with this medication. So it's peas in a pod. You always give them together. And then with the cyclophosphamide, you frequently see them in combination together. So that's what those parentheses mean, required/frequently. Fun fact, all the anthracyclines are bright red in color. This will not be on your board. So just like rifampin, you guys remember from TB? So they cause your urine, tears, and other secretions to look like Kool-Aid. Oh yeah. Oh no. So rifampin isn't it. You guys remember when Michael Jordan would sweat Gatorade? You guys remember that? Was that before your time? But I always think of, when I was in school, Michael Jordan was sweating Gatorade. So I always thought of rifampin with those Gatorade commercials. But you will see the rifampin and the TB. Remember, you will see those and those signature side effects on board questions. But I don't think for chemo. I don't know if they'll put that. But that's just a review for. So that's what I'm saying. So super hang on again. That was kind of the intro part. So now we're going to go into targeted biological therapies. How are we doing with time? We're doing OK. So in 2001, it was a good year. I know you guys were like in first grade, so I don't care. Don't tell me how young you guys were. Because the undergrad kids are killing me. They're like, oh, what? 2001. So I was in college here, but so super old, right? But 2001, never forget. There was a big shift. Everyone was excited. I was pre-pharmacy, so I was excited just because pharmacists said this was important. But so there's a shift from cytotoxic chemotherapies to targeted molecular therapies. So you guys remember Gleevec? No, probably not. I don't even, yeah. And Gleevec was awesome. So Gleevec was that game changer with cancer. Everyone got super excited. People were losing their minds. There were, finally, like the end of these toxic, crappy drugs. This is the future now. It's going to be targeted. So spoiler alert, there still are the crappy toxic drugs, and they still save lives, and they're good and all. And there are more targeted molecular therapies, but they're still pushing towards that, and they're still developing it, and it is still what most smart people think is the wave of the future. So you guys will probably see a lot more of these targeted molecular therapies in your practice. So they're relatively speaking more focused, so which is good, because I mentioned too some of the concerns with cancer is you don't want to kill the whole person. Because yeah, you kill the person, like we killed cancer, but then the person's dead too. So you got to kind of watch out what your goals are and what you're really trying to do. You still have to be concerned with adverse effects, but you're less concerned with off-target adverse effects. So you're less concerned with hair loss maybe, or less concerned with some of those other things I mentioned, those common adverse effects, et cetera. But you still have adverse effects, and they still are kind of messy. So that's where everyone was initially super excited, but then you still have to think about adverse effects. But the good thing for students, or I think, is that they make more sense in the sense that they're more specific adverse effects for the specific therapy. So that's where it's at less off-target adverse effects. So we have these MABs, monoclonal antibodies, which usually is IV administration. And then we have the tyrosine kinase inhibitors, TKI, PO administration usually. So this was another big game changer too. When the tyrosine kinase inhibitors came out, everyone was excited because you could maybe give it to a person without IV, and then you don't have to worry about infection and all that other stuff with IV. People don't like IV, et cetera. And so you could kind of like send them home with PO versus requiring them to come in to get their chemotherapy. So that was another big game changer there, and people were excited. So the monoclonal antibodies, I think I've already talked to you about this, but just as a review, they all end in MAB. So for monoclonal antibodies, they'll have that suffix. They are target specific, so which is good. It's more specific. So they should only bind to whatever thing they were designed for. So this is where you always hear, you guys remember undergrad, lock and key, lock and key. I'll try not to use too many hand gestures, but that lock and key. So each antibody binds to a specific antigen. So that's where you always, that's that undergrad. I remember Dr. Ahmad was always lock and key, lock and key. So that's where the antibodies come. So for example, you make a MAB, you make a monoclonal antibody for the HER2 protein, Herceptin, which is that helped in number. So it'll only bind to that HER2 protein, so more specific. And here's just a visual representation, just for review, antigen binding site. So this is where you see these different keys and these different locks, so to speak, antibody, antigens. So just a review. And I'm assuming you guys will get that in pathophys, right? Maybe? And if not, well, here you go. You're welcome, Dr. Fruki. No, I'm joking. Nomenclature. I love words. and names and stuff. But so I was excited in pharmacy school about this. I was probably the only one. I was like, yeah, words, these are great. And they're like, sit down, Charles, quit standing during lecture. No, I was at home on my head. But so nomenclature. So I don't know who decided on this, but thank you, whoever, if it was scientist or pharmacy or big farm, I don't know. But they help tell you the source of the antibody. So anytime you see an O, that means mouse. So all mouse. XI means chimeric, so that's a hybrid. So that's part human, part non-human, sometimes part mouse, part, it's like Mickey Mouse. No, I'm kidding. He's not chimeric. Part mouse, part human, maybe. Humanized, you'll see the ZU, so that's mostly human, and a little bit of part non-human. And then the U is for human, all the time. I don't know. I just thought that was funny but yeah, so it's just all human. I don't know why I thought that was funny. So here is a visual representation of that. So let's go back. I'm going to go back and forth. So take your Zofran to nausea, vomiting, right? So O, mouse. Blue is mouse, all mouse. XI, Mickey Mouse. It kind of looks like Mickey Mouse, right? M-I-C-K-E-Y? No, I don't know. So XI is oops, wrong way. XI is Mickey Mouse, chimeric, part human, part non-human. ZU is humanized, right? So this is like our, what all the sci-fi dystopian movies are made of. But this is humanized. So mainly human, and this is all human all the time, 24/7. Oops, yeah, all human all the time. Nomenclature, more nomenclature, because you guys are so excited about it. I just had to keep going with this. But so then on top of that, they also gave you more clues when you look at these drugs, because the 2 letters before the source gives you a general idea of where it works, the target. So it kind of leads you. So here are some common targets. And the letter in parentheses is optional. So you'll see C or you'll see CI together. So that's what. So if you see a C, you think circulatory system. If you see a K, think interleukin. An I, immune system. T for tumor. Can it be that it was all so simple then? You guys Wu-Tang fans? Wu-Tang? All right, Wu-Tang, yeah. Wu-Tang forever. You guys remember that song? Well, okay, whatever. But they had a song, Can It Be So Simple Then? So I wish that that was my wish, that all drugs could be like that. Like you just look at the drug and be like, this is what it's for. It has a U, but it's not. All right, adverse effects. So they're good, and they have less of those general adverse effects, but they still have adverse effects you have to worry about. Infusion reactions, put a star by that. Anaphylaxis, put a star by that. SJS, put a star by that. Why not? Now, these are all very important, all joking aside. Box warnings, etc. These are the ones that, so they are, relatively speaking, better than other chemotherapies, but they still have adverse effects you have to think about. So infusion reactions. And then with these infusion reactions, anaphylaxis, SJS, going back to those part human, part mouse, the more human it is, the less likely you'll have this. I'm not saying never, but less likely. And the more mouse or the more non-human it is, the more likely you'll have it. So for example, mouse protein would expect it to have more of an immune response than the human protein. So, but then I put this here too because it's like, don't think that you don't ever have to worry about it. So this Darlazex is a human, right? So it has the U wherever, but it still has a 48 risk of infusion reaction. So again, it's a general rule, but just still you have to squint at some of these newer products, and you still have to squint on them, even if it is all human. You have to think about that. So there are some mitigation strategies, and so you'll see these implemented a lot to try to help with this adverse reaction, because it's just one of those that's known. It's a textbook one. It's on the board questions, etc. So a lot of times you'll see a pre-medication. So this is one where, going back to our allergy lectures, you'll see H1s and H2s. They basically just throw any histamine blockers. Just here you go. So like Benadryl and cimetidine, or I don't know, or Benadryl and famotidine maybe. Instead of cimetidine, or ranitidine, Benadryl. This is generic Benadryl. That'll happen. I mean, that will help. Tylenol can help sometimes too. Acetaminophen is generic for Tylenol. And then steroids. So you see dexamethasone a lot of times too being given. So steroids too. And so all that pre-medication cocktail. And the joke in pharmacy school too is like, and you can give them a cocktail too, tell them to relax. But I'm not going to make that joke. That joke's lame. But so it's a specific cocktail of you want to block all the H's, H1s and H2s, Tylenol maybe, so antihistamine, and then steroid to help mitigate that. So you see this a lot, just given before. Other mitigation strategies is you definitely want to start low, go slow. So titrate the infusion, start slowly, And then and then it's going to be based on the patient's response. So if they're tolerating it and they're not having a reaction, et cetera, you can increase the rate of infusion. Good news is there are specific protocols for specific medications. And your hospital, your facility, if you're at the cancer center, they have all those, in protocols, et cetera. So they'll give you, there's charts that I've seen where it just tells you which one you're giving and then which specific infusion rate is recommended, et cetera. So I'm not going to make you guys memorize that stuff or look at that, but just know that there are different ones. But in general, even not dependent on the guidelines, you want to kind of start slow and then monitor that specific patient to see how they react to that mouse or to that chimeric or whatever combination you're given. So a patient is more likely to have a reaction the first few times receiving the infusion, and the risk does go down with each dose. So the total infusion time is likely to decrease over time. So you start slow, maybe for the first few times you give it to the patient, but then eventually you can maybe get quicker. And then again, patient-specific, if they are not having an anaphylactic reaction, then you can maybe increase it and speed it up over time. So you definitely will see that process done. Some more mitigation strategies. There's another strategy where you can stop the infusion if they start maybe having some reaction and administer IV steroids. So like I said, the dexamethasone usually. There's other ones too. And then Benadryl, diphenhydramine, will be given. And then you can restart the infusion at half the rate it was running previously. So again, you're going based on your protocol, and it's so many mils per minute, and the person starts having a reaction or whatever. You stop it, give Benadryl steroids, and then you cut that rate in half. If the patient reacts again, then you're going to need to try another therapy. Because of SJS, anaphylaxis can be life-threatening, they can be serious. You don't want to keep re-challenging. So they typically will just try a second time, and past that they're just like, all right, we don't want to kill this person. So they don't keep re-challenging. Other ones, these are some examples of some specific medications that have specific adverse effects. So the point of this slide is just to show you that, like I said, it's relatively speaking less of the common adverse effects, but you still have to be worried about adverse effects. And again, this is the specialist game. They know these like the back of their hand. They know Herceptin and blah, blah, and they know but for me, a regular pharmacist, when I'm at wherever I'm at, Fry's Pharmacy, if you ask me these, I'll be like, I got to look that up. I'm like, great question. Let me look that up for you, and I'll get you a patient printout or something, because so don't worry about memorizing these two. That's just to show you. That's just the point is that these still have adverse effects you have to be concerned with. So related to target therapies, the TKIs, tyrosine kinase inhibitors. So the mechanism of action, these stop cancer cells on a genetic level by inactivating certain signaling cascades. So they always talk about it being an on-off switch for whatever protein or gene they're coding for. So with cancer, the pathological problem is that sometimes these on-off switches mutate or they get stuck on, and then you get uncontrolled growth. So the rationale is give this TKI as to help with that on-off switch. Most are given PO, yippee, hooray. Patients love that. They don't like, majority of people don't like needles, they don't like IVs, et cetera. So that's something that is a big advantage of the TKIs. Adverse effects, so these are signature ones, and remember these, but so the acneiform rashes sometimes can progress to SJS, excuse me, often treated with topical steroids, maybe a 6-week course of doxycycline is recommended. And then rash and diarrhea is a big one. R&D, research and development? No, rash and diarrhea. So I got this research into, because anytime I hear R&D, I think of research and development. But so you can think about when you rub money on your skin, you get a rash, and then you have electronic diarrhea. I don't know what this side's supposed to stand for, but R&D, rash and diarrhea. Just remember that. Drug interactions. So unfortunately, you have to be concerned with drug interactions for TKIs. And specifically PPIs. So this is your omeprazole. Omeprazole is ubiquitous. The PPIs are ubiquitous. So definitely for board questions, for testing purposes, et cetera. TKIs, contraindicated with a lot of the PPIs are contraindicated with a lot of the TKIs. Just memorize take-home point. I'm not going to make you memorize the specific ones, but so when you see TKIs, I want you still to think about drug interactions. You can use the histamine 2 blocker. So I mentioned famotidine earlier, but then you do have to separate the dosing. So there's this specific recommendation there. So if a person needs to be on some kind of acid-suppressing agent, avoid PPIs and go to the H2 blockers. Super hang on. I think we can maybe get through another one. So chemotherapy-induced nausea, vomiting. So first, you have to determine the metagenic potential of the chemo you're giving. So this, again, will, depending on the facility you're at, they'll probably, I mean, this is something you can look up on UpToDate, et cetera. They have guidelines, they'll have protocols. So at these cancer facilities like the Texas Oncology, they'll have, if you're giving these chemotherapies, these are preferred nausea, vomiting medications, antiemetic medications. And then you also need to determine the risk of delayed emesis. So this is where you send the patient home, and then they have 24 hours plus after treatment. So that take-home prescription, which I fill out outpatient, that take-home prescription for nausea, vomiting, you need to think about too. And again, it's going to depend on the specific chemo you're giving or the patient's on. ASCO and NCC both have guidelines. Yippee, hooray. So you guys don't have to worry about, you're not out in the dark. I'd recommend either one. I think one of the two guidelines is just free and open, and the other one requires you to be a user. It doesn't cost money, but if you end up working in a chemo, I mean, or with a specialist, I mean, even if it costs money, it's going to be your bread and butter. You're going to be prescribing these like crazy, and so it's good to know and to follow the guidelines. The individual clinics, hospitals, et cetera, they also have their own protocol and guidelines. They're usually based off these two. But so just also to ask for protocols, ask for guidelines, et cetera. Oh yeah, here we go. Institution, we work up a protocol. Woohoo! So that's nice. I always appreciated that as a student. My first day on rotations at new facilities, I wanted all of their whatever their in-house protocols, et cetera. Like I either needed online access to it or I wanted to print it out or et cetera. Because it really, not only is it good so you don't step on toes when you're at that hospital, but it's also good because it's based off evidence-based medicine. So it was always a good refresher because I hadn't seen some of these drugs for a year or two in lecture. So it was nice to have the protocol because like, oh yeah, this is what, yeah, and these are for that, yeah. I remember. You start kind of remembering things and stuff. So that was something I would always do first day rotation. So golden rule. Do unto others with, no. CINV is much easier to prevent than to treat. So that's what the guidelines are based on, and that's the motivation of practitioners. You're going to want to try to prevent this nausea, vomiting, instead of once it happens, they have dehydration, et cetera, and you're kind of chasing your tail. So here's a summary of current best practices. This is that pharmacotherapy. Based off the guidelines. I pulled a little bit from the guidelines. Don't stress about going to the guidelines and feeling like you need to memorize them and go through them. Just worry about what I pulled out and put on the slides. So if they have a minimal, and this vomiting risk, et cetera, these are all defined in the guidelines. So minimal, low, and moderate they're formally defined, and they'll be defined on protocols, et cetera. So if they have if the medication has a minimal immunogenic risk, you don't have to do any prophylactic. If it's low risk, you'll go with dexamethasone or any first-generation serotonin blocker, 5-HT3 blocker. So Zofran, ondansetron, usually. The dexamethasone, so students ask me this all the time, mechanism of action, dexamethasone, nausea, vomiting. So it's one of those, question mark, they don't know, it's not fully elucidated why it helps. They have some good theories out there, and they have some really neat little paragraphs you can read. I didn't put it in here, but just know it's one of those where they're not really sure exactly why it helps, but it helps. If they have moderate risk, so you do the combination, so Zofran plus dexamethasone. And if the patient develops severe refractory, you can add an NK1 antagonist, which I'll talk about here a little bit. I'll review because it was in a presentation we'd already gone over. If there's any risk of delayed emesis, you can continue the dexamethasone for a few more days, or give this specific serotonin antagonist, palinosterone. The reason that one is preferred if it is longer term because it has a super long half-life. So it'll help cover the patient for maybe 5 days, maybe a week. So that's why that one specifically is preferred if you are wanting that longer term prophylactic coverage. So that's good stuff there. Severe metagenic risk, you go with an NK1 agonist plus serotonin antagonist plus dexamethasone. So you kind of see it's kind of like aspirin. It's kind of like asthma, right? You're kind of stepping up. So you kind of just keep building on that. Anticipatory nausea, vomiting, you can go with a benzodiazepine. Interesting, right? Usually you go with lorazepam because you don't have to worry about it accumulating in the liver, and then you don't have to worry about their kidney with lorazepam, so you don't have to worry about renal failure. So a couple reasons. So you will see lorazepam sometimes prescribed for patients that are on chemo. Breakthrough nausea vomiting depends on what works and depends on what your patient's medical history is, other medications. So this is kind of a grab bag. So this breakthrough nausea vomiting is really going to be custom. I've noticed that there's certain oncologists, they just like certain things, and that's what they prescribe all day. And some of it's based on protocol, some of it's based on guidelines, some of it's based on their own. So this is going to be a really custom kind of, there's no consensus, really custom. So we have all these listed here. You notice olanzapine, so older antipsychotics, newer antipsychotics, older antipsychotics, promethazine, metoclopramide, dronabinol, J-Lerm, I'm looking at you. Depending on what state you're on, you could use dronabinol's more natural cousin. So that's what we have here. You know what I'm talking about? J-Lerm does. But yeah, so if you're in where they have medical marijuana, this is a big place where medical marijuana is used, is for this nausea vomiting. And part of the reason that the states, California in particular, why they legalized it. Does anyone watch Last Week Tonight with John Oliver? Okay, he had an interesting piece about medical marijuana this last week, so it was interesting. I'll just say that. So then some more pearls for chemotherapy-induced nausea vomiting. Was there a question? Or did I just see someone's hand go up in my mind's eye? Okay, never mind. All right, that's cool. No, it's fine. I see things occasionally. It's cool. It's not, I don't need to be on antipsychotics, I promise. So they do make, Blockbuster, they do make a new drug. It's called, and I can never say this, Akynzeo, I think, is how they say it. Akynzeo. Don't quote me on that. But it has an N1 antagonist and that second generation H3 blocker, HT3 blocker. So Sarah has a couple different medications. The Natupitant and the Palonostrel. Jeez, I'm totally tongue-tied. This medication always throws me off. I can say it fine in my office and like when I'm by myself, and then in front of people, my sympathetic nervous system doesn't allow me to. So the big advantage over that, it is a single PO dose, and it helps cover both the severe and delayed. So people are really excited about this. You can still use dexamethasone with it, but don't add any other NK1s or serotonin antagonist. So for a long time, this is just more clinical pearls. So for a long time, Emend was the only NK1 antagonist. And then it's an interesting one. So Emend is one of those drugs that it has two different, one brand name, but the IV is specifically the phos apripitant versus apripitant is the non-IV. So this is the, but anyway, so that's just, but they're both Emend. And usually people just refer to them as Emend. So you can give that PO as a 3-day regimen. There is a drug interaction with dexamethasone, but it's okay. It's not an absolute contraindication to give them together. You just need to remember to decrease the dexamethasone dose by 50% if you are going to give it in combination with dexamethasone. So you can prescribe them then with dexamethasone. Just think about lowering the dose, cutting it in half of dexamethasone. And then we have Varubi, which is a newer one that's been developed. So this is a little bit different than Emend because you just give a one-time PO dose, and then it does not have the drug interaction with dexamethasone. So this is the newer one. It's more popular. Unfortunately, it is a lot more expensive, so I don't know as far as practicing. I don't dispense a lot of these, so I don't know if it's going to really take over or not. But thank you for that, whoever that was. Appreciate it. Thank you, robots. Yeah. They're going to take over soon. But other than that, so other than those little clinical pearls and maybe some like this one has, it's PO advantage only one time by mouth. You don't have to worry about drug interactions. They're all considered equivalent, therapeutically speaking. More pearls. You guys like the pearls, so here we go. No. So all of the first generation serotonin antagonists are considered equally efficacious, except for this one I mentioned has the long half-life. So it's sometimes advantageous if you want coverage prophylactically for 5 days, et cetera. You typically out in practice will go based on the formulary preference. So your hospital, facility, et cetera, will already have it. And then dosing convenience too. So how often is it dosed? Do they make it in a patch or do they have an oral disintegrating tablet, ODT? That may help, especially if a person has problems swallowing. So that may be a rationale to prescribe that. Definitely note this. So they all first generation serotonin antagonists are associated with QT prolongation. So that's something you have to think about sometimes. And if they are at risk for QT prolongation, then you go into aloxi, which is a newer serotonin blocker, and it does not have the QT prolongation. However, it is very, very, very expensive, so you really need to have a rationale that you're concerned with this patient specifically with QT prolongation to prescribe aloxi. And it's usually, and it'll be on the formulary, but then it'll have that asterisk and kind of fine print like, hey, there better be a good reason for this because it's super expensive. You're going to get a call from the pharmacy if you're just willy-nilly prescribing this. Finally, you can use any steroid. However, conventionally, historically, they've used dexamethasone. So there's some reasons. One, it's just been done historically. It is the most studied. There is the most evidence supporting its use. It doesn't have the mineralocorticoid activity, so that helps. In that if you want to push the dose, you don't have to worry about the fluid retention. So that's an advantage of dexamethasone. So usually when you hear steroids for chemo, usually it's dexamethasone. That's the one you can go with. Yeah? Good question. You didn't see my up arrow? No, I'm kidding. Yeah, so this specific serotonin blocker has an increased half-life. So it's the one on the previous slide. You remember, you can give it prophylactically if you're concerned about covering the patient for like 5 days. So, and it kind of depends on the patient, but say like a week or so, a business week. More pearls. So you can actually use any steroid, like I said, but dexamethasone is a take-home point. Oh, I just repeated that. Okay, so that's exactly repeated for here, so I don't know why I did that. Super hang on. So I think I'm going to stop there. Any questions about, we got some fun stuff. So any questions so far about what we've covered?